my name's Hannah, and we're here at Fitzpatrick Referrals today, and we've opened up our brand new dentistry referral service that started here in January. And we've already seen a really lovely bunch of patients, so much so that I've managed to fill pretty much this whole presentation with lovely patients that we've recently seen. We're a reasonably small size team still at the moment. We've got me and Lindsay, but soon we'll be adding a third person to our team as well. I am a vet. I've been a vet for about 10 years now, nearly. I worked in primary practice for about 7 years before I really found my passion for dentistry. And then I have recently completed a full-time residency over at Eastcott Referrals in Swindon. And then I ended up here. Lindsay has come to me probably with even more dentistry knowledge than I have, having previously been a human dental nurse for 20 years. So I've been really, really lucky to be able to pinch her from the kit team here. And not only does she give me loads of cool insights about human dentistry, but she's mostly behind the scenes making sure that really everything in the department keeps working. So all the instruments, absolutely everything is tip-top in order. And then, as I said, soon we'll be adding our very own dental RVN to that mix as well, although we've had a really lovely set of RVNs from all around the hospital rotating through the department at the moment. So that's been really fun as well. We've seen a really wide variety of cases. So even in just the last few weeks, we've seen everything from good old root canals and crowns, a few malocclusion cases, to odontogenic cysts. This one specifically was in a tiny 2-kilo Chihuahua. Some complex extraction cases where we need either really complex types of teeth, like those with end-stage tooth resorption, or those that have really complex anesthesia needs. And recently, in the last 2 weeks, we've been seeing quite a few jaw fractures come in as well. One of those was the little ginger cat there on the front one, with more and more to come, really. But we're here today to mostly talk about cats. This is Barry, one of our recent patients. And mostly we're going to talk about all of the hurdles that come with having cats as patients, because they're just not small dogs, really, are they? And mostly we're going to try and focus on trying to make your life as easy as possible, which I think is always nice in dentistry. Most people experience with dentistry is that it's hard, difficult, not particularly fun. And I think particularly in cat dentistry, that's where that comes out more than anything else. And interestingly, you wouldn't exactly think it, but making your life easier already starts at the point of admission when it comes to your cats. And that's because cats are really, really stressy creatures. And the stressier they are, the stressier the owners are going to be, the stressier we're going to be, the more anesthetic you need to keep them asleep, the less stable the anesthetic is going to be, the more rushed you're going to feel, and the more things are going to break, because that's just the way that dentistry works. So particularly when it comes to cats and thinking about their stress, there are lots of different things we can do to try and manage that stress. And the now called International Cat Care Veterinary Society, which just renamed themselves, have some really lovely documents on that. So there are things that we can do in our waiting room, there are things we can do within the exam room, with the admission appointment itself, like maybe scheduling it at a time where the waiting room is not full of barking dogs, all the way down to our wards rooms. So it might not be possible for everyone to have a completely separate cat ward, but again, trying to put those cats in an area where it's a little bit quieter, where maybe they're a little bit more zoned off from everyone else, or at least have the ability to hide away and be nice and quiet if they're scared. Through to our prep room, which can be a really busy area, not fantastic if you're a cat that's quite scared and skittish. And also to planning out that day and trying to do things like having really stressed cats in and trying to do them first thing in the morning when hopefully some of the drugs that they've had are still on board, and not at the end of the day when everyone's tired and wants to go home, and particularly the cat who's been sitting next to your barking Chihuahua all day. And one of the things you can do easily, even if you don't have access to the huge page documents that ICC has, is just have a little think when you look around you and think about all of the different aspects of hearing, sight, touch, and smell that cats have. They're incredibly sensitive creatures because they sit in this weird place between being a prey and a predator animal. And that means that their senses are really keen and really acute. And they might hear and see and smell things that we don't really even think about. A small example is we had a lovely cat called Kiki in the other day. And just before I went to examine Kiki's mouth, I'd had a lovely snug with our office dog, Harrison. Harrison's got a little bit of lip fold dermatitis and he smells pretty bad. Kiki's normally really good with me looking at her mouth. She doesn't like it too much, but she'll let me. That particular day, she was in such a bad mood. And I can only think that the smell of Harrison's mouth on my hands must have been just the worst possible thing I could have ever put near her face, especially as she's a Siamese. So she did not forgive me for the entire day. There's little things like that that we can just sometimes adjust a little bit just to make things a little bit nicer for cats. And then we can pull that through into our anesthetic considerations as well. Again, thinking about all of those stress factors, we can think ahead if we know that the patient's a stressy cat or an anxious cat, whether or not that means that they're anxious and they want to hide away, or they're anxious in the type that they want to really hurt us if they have the possibility. We can think about preoperative anti-anxiety medication, and the most common one I'll use is gabapentin. And normally I'll use about 10 to 15 mg per kg with about a maximum of 100 milligrams per cat. If I need more than that, then there are doses of trazodone that can be added into that as well. And considering things like whether we really want to push for an IV pre-med, or whether we maybe give it one shot, and then if that stresses the cat out too much, or if we think that they're going to be really stressed out by an IV, that we just design an IM pre-med for them. I'm quite a fan of the now named restrainer container. I don't use it that often, but some cats will be fine with very gentle compression, but if you have to hold them with your hands, they hate that. So taking those kind of things into consideration and trying to reduce those stress moments can be really helpful. But even beyond stress, cats are notorious for not drinking very well. They're historically partially desert animals, so they're very, very good at maintaining their water and getting a lot of water requirement from their food. But especially as they get a little bit older, they tend to always lean towards the mildly dehydrated form of what they could be. So if we think about those kind of things beforehand, so making sure the owners leave water down, maybe especially in cats that are more prone to dehydration, like our kidney cats, potentially those owners could be adding some more water to the food in the few days beforehand, considering whether these cats would be better coming in and staying in overnight on fluids, or whether that's actually going to stress them out so much that it's not going to have the additional benefits. Keeping them nice and warm and dry from the get-go. They're tiny creatures. Some of them are really fluffy, some of them are really fat, but hopefully nowadays the majority of them are a pretty normal weight. And what we're doing is we're using equipment that has lots and lots and lots of water cooling, so they are going to cool down quite rapidly. And if we can already keep that temperature up from the moment that we've pre-medded them, instead of trying to fight back on the cooling down temperature, once that happens, we're actually winning before we even start. Multimodal analgesia is always important with any kind of patient and can sometimes be a little bit tricky with cats because our choices are a little bit more limited. You can't just grab paracetamol. And we might not always be able to grab NSAIDs either because they might not be the most ideal patient. But we can certainly think about the types of opioid drugs that we're using, if we add things like ketamine or ketamine CRIs in when we're doing a lot of extractions, and even thinking about like little low doses of alpha-2s during procedures as well. And then also our local anesthetics. We'll talk about local anesthetics lots more later, but what you'll notice, there'll be a table in there with some doses, which you're more than welcome to take pictures of. And the doses for cats have a tendency to be lower than the doses in dogs, and this because cats just aren't really that good at dealing with a lot of drugs and medication. So their doses tend to be lower. So it's really important that we keep that in mind, that we're calculating our doses correctly to make sure that we're not using too much, but that we're also not using too little, and that it's not having the effect that we want it to have. There's always a big discussion when it comes to the next step of anesthesia, which is to cuff or not to cuff. I'm very much a cuffer, and that's because, again, I work with machines that have a lot of water. I work in mouths that are really dirty, and I really don't want any of that to be going down into the airways. And even with a tube that fits really nicely and really well, if we're not cuffing it, we're not creating a really adequate seal to really protect those airways as much as possible. So by using a cuff, definitely benefit of superior airway protection, but it does carry risks with it, and we need to be aware of those. And these mostly include local ischemia of the tissues within the trachea, and the one that everyone is really afraid of, tearing the trachea. But we can manage those risks as much as we can. And I've put a little picture up of two of the equipment options that we can use for that. They're both manometers. They also lidocaine spray. I should have put them upside down. We've got the lidocaine spray, which we do need to put on, but we also need to wait for it to work. I'm terrible at waiting for things to work. And the only way that I can make myself wait is by doing something else. People who know me well know that a lot of my patients go home with really clean ears because I will busy myself looking at whether they have little bits of gunk in their eyes or gunk in their ears, because it distracts me long enough that I'm actually giving that lidocaine a bit of time to actually do its job and work, so that I can intubate my cats a little bit easier without having to give them lots and lots of propofol or Alfax. Then we've got our manometers, and we use these to measure how much pressure we're actually pushing in the cuff. And that's one of the things that we're using to manage that risk, particularly of local ischemia. And with cats, and with dogs as well, we want to be looking at a pressure of between 20 and 30. But with the cats, I tend to keep it on the lower side of kind of 20 to 25. You do have to have the right ET tubes for this. So you have to have the high volume, low pressure tubes, which are the see-through ones with the kind of more elongated cuff. Because the orange ones have a rounder cuff, so you get more of a pinprick, kind of like standing on a wooden floor with a heel versus a shoe. Even though the pressure in the cuff might be the right pressure, the pressure on that pinprick point is going to be much, much higher. So you could still get areas of local ischemia. But if you're using the correct type of tube and you're using these manometers to check what your pressure actually is, you can ensure that you're getting a good enough seal to prevent anything going down the airways, while also maintaining that perfusion within the soft tissues. And then the big thing with the tracheal tears is that they actually, if we look at when they are most likely to happen, when we're flipping the patient. Some dentists are amazing and they can do everything with their patient lying on their back. I've tried it, it's not for me. So there's no shame in saying as a dentist that it's not for you. I like doing everything on one side, and then I flip my patient, I do everything on the other side, and sometimes I flip them back as well. So the most important thing there is making sure that we're disconnecting our patient from the machines while we're flipping them, and that we're supporting their head and their neck as we're doing that. So we're preventing that tube from moving around and flopping around. And that's a really good way to manage that risk of tracheal tears. And knock on wood, I've not had one as of yet. I feel like now I'm going to get one tomorrow, but hopefully not. Back to cat teeth. Cat teeth are probably one of the most interesting set of teeth. I get really enthusiastic about teeth on a bad day, but particularly cat teeth, because to me, they're such a specialized version of teeth. Cats have very little teeth, they only have 30. And when we look at the ones that they do have, with the exception of their tiny nubbins of maxillary molars, which I don't really understand why those are there, all of the teeth have really specific functions that kind of lower back to that big cat hunter lifestyle that they could have had, and they still try and have on occasion. They really have no more teeth than they need. And most of their teeth have this triangular cutting design to them. They don't do a lot of chewing and grinding. And actually, when we look at the shape of their temporomandibular joint, they don't have a lot of ability to move their jaw from side to side either, because they're really just trying to cut food into smaller chunks and then swallow the chunks. As a result, they have a really tight occlusion. They don't have a lot of space in their mouth. So if you've ever seen a cat with supernumerary teeth, that often becomes a problem really quickly because they just don't have the space to deal with that. And if we have any malocclusions, either because teeth aren't in the position that they should be, or maybe because we've had a fracture previously and that hasn't quite healed in the way that it should, then that can very quickly become a problem for cats, because there's just not a lot of space for teeth to sit in even a very slightly different position than where they should be. But most importantly for us is that they have really fine, really thin little roots. They have really fine, thin gingiva, and they have really fine, thin bone. So everything about them in extractions is terrifying. We can make it slightly less terrifying with some semi-cat specific instruments. One of the most important ones is your Sharp Explorer. Sometimes that's a separate instrument, sometimes it's on the back of your dental probe, and it's that really sharp hook-like object. And the most important thing we use it for in cats is probing and feeling for resorptive lesions around the neck of the tooth, so where the crown meets the roots. And that's because tooth resorption is incredibly common in these patients. And even really, really small lesions could be really, really painful for them. And they might not even show up on X-ray that well, but you can certainly probe them if you've got a nice little Sharp Explorer. So that's definitely one to add to your cat kit. One of my favorite instruments for cats that I can never go without is a fine periosteal elevator. Periosteal elevators, if they're sharp and they're a reasonably small size, are lovely anyway. But the nice thing about this one is it's got a really small, very straight head. If you look at the ones that are more designed for dogs, they're kind of curved and spoon-like, and they have a tendency with cats to kind of push the mucosa off of the bone, instead of us really doing that undermining and then lifting it off the bone, which is what we're doing with periosteal elevation. We don't really want to slide it off the bone. We want to lift everything off the bone. And that's what these instruments are really, really good for. So if that's something you struggle with, especially in areas where things are really tight, like around that maxillary canine, this can be a really, really nice instrument to just help you do those little elevation movements and reduce the risk of you tearing your flap to begin with. Those really tiny little annoying little root tip burrs, absolute game changer for these guys. I love a root tip burr. I have at least one colleague who doesn't use them, but instead uses a surgical length, really small size round tip burr. Does pretty much the same job. And what we can do with those is, if you do snap a root, is you can basically use them to cut around the tooth roots, kind of where the periodontal ligament space would be, instead of having to do a big alveolectomy on the buccal side of the bone. So you're still getting that same effect of basically removing that periodontal ligament and undermining the connection of the tooth root to the bone, but we're not having to remove as much bone, which means that we're also at less risk of, for instance, fracturing something. And especially when you've got a teeny tiny little tooth root, staying away from the mandibular canal is always a good thing. And this kind of can allow you to do that quite easily as well, because you're more cutting in between the bone rather than really removing the whole wall. Same goes for really small type instruments anyway. So if you don't have a size 1 luxator elevator, definitely make sure to add that to your kit. And you can even get things like a size 1.1 or 1.3. So you've got these kind of intermediate sizes instead of having to jump straight to a 2 as well. And then a fine extraction forceps. Your normal extraction forceps can be quite clunky when it comes to cat teeth, and especially if you've sectioned the root, or you'll sometimes find when you clip them closed, the tip of your extraction forceps doesn't actually fully close, and you just end up trying to grasp this tiny piece of root and it's just not holding on to it. But a set of fine extraction forceps will actually close all the way at the tip, so it will allow you to actually hold on to the tooth instead of your extraction forceps just sliding off it all the time. And then for those really annoying tiny little pieces of root that are pretty loose and they're wobbling around, and you're like, if you can lie on your side, why can't you come out? A root tip forceps is a really nice additional tool to have. And it sounds super fancy, but really all it is it's just a really pointy forceps that can just allow you to just grab the sides of that little piece of root and just pull it out, instead of having to try and lever it out with your really nice elevators that you really actually don't want to bend in that way. And then small X-ray plates for these guys as well. So size 2 plate is kind of a must for any cat, but sometimes you get cats that are really, really tiny. And I find with those, having a size 1 or having a size 0 plate in my arsenal can actually be really helpful. It's also really helpful for all your teeny tiny teacup Yorkshire Terriers and your Pomeranians, where you really, really struggle to get a size 2 plate to fit all the way in that mouth. Tiny plate, fantastic. You won't use it as often as your 2, but when you need it, it will save your life. And because everything's really teeny, teeny, tiny, being able to see everything is really important. I'm terrible for this because I'm really, really nearsighted. So I actually see things up sharp, up to closer than a normal person with normal eyes who doesn't have -8. So I'm really tempted to get really close to my patient and really squint. And that's where Lindsay's fantastic, because she doesn't let me do these things because it's bad for my back and it's bad for my migraine. So instead I get my loops out, and I've got a really fancy set of loops because I'm doing this work day in, day out all the time. And if I have something that's not adjusted to my eyes specifically, in the long run, I'm going to get headaches. So this one's set specifically to my pupil distance, to my working length. But if you're not doing this like me every day, all the time, a cheaper set from Amazon works just as well. And this is the set I started out with a really, really long time ago. And it literally costs 50 quid. And it comes with a light on top as well. And when you're trying to find these teeny tiny little broken roofs, and you can see it on the x-ray, but you just can't see it in the cat, getting some loops out and getting some actual good light in there can definitely give you that needle in the haystack moment. Dental x-rays are an absolute must. I'll always hammer on about it, and I think every dentist will, that really we shouldn't be doing any dentistry without dental x-rays, particularly in our cats. We've got a really fantastic study, it's now about 26 years old, that shows that if we just look at a mouth and the mouth looks totally normal, we've probed it, done nothing else, and we think we don't need to x-ray this one, that we'd actually be missing clinically important lesions in over 40% of our cat patients. And even in the cats where we do think, oh, that's a bad tooth, that needs to come out, it's giving us additional information in over half of our patients, and about a third of our patients, that information is going to be essential to what treatment option we're going to do. Nothing is quite as important in that as tooth resorption in cats, because you don't know if you can crown amputate a tooth unless you've taken an x-ray. And you don't know if you've crown amputated it enough or done it as well as you could do if you don't take a post-op x-ray either. That being said, it's also just really good to plan for things. And we do see some anatomical variation in our cats. We mentioned our cats with supernumerary teeth, but even those that have a normal amount of teeth tend to have a lot of differences in roots. That maxillosecond premolar, the most common variation we'll see is that it's got fused roots, or it's got two roots. The fused roots are really easy to break. The two roots, easy to miss one and leave one behind. Same with the maxillary first molar. Sometimes it's got two roots, sometimes it's got one root, sometimes it's got fused roots. And if you don't x-ray, you just don't know what you're going to see, and you don't know how much you need to be extracting. And then the one that I've fallen for, definitely, is the supernumerary roots of the maxillary third premolars, which we find in about, surprisingly, in about 9% of cats. And I've had it before where normally if I'm quite confident I've extracted a tooth in its entirety, I'll suture it up before I x-ray it. And that works for me like 99% of the time, with the exception of this cat, where I'd missed the additional root because it was in exactly the same line as one of the other roots. If I hadn't done that post-op x-ray, I would have totally missed it. It was so obvious on that. So I went back and then I took that out, and then I had to resuture everything, which was a pain. But I'm glad I did it anyway. Cats' x-rays are nearly similar to dog x-rays, with the exception that cat skulls tend to be a little bit flasher and their zygomatic arch is more prominent. So they can be a little bit more difficult to x-ray that maxillary arch without getting the zygomatic arch in the way and overlapping the tooth roots. The specific view that we sometimes do with cats is this extraoral near parallel view. So instead of putting the plate inside the cat's mouth, we're actually putting the plate on the table and then putting the cat on top of the plate with their mouth open. And then we're coming at that almost straight to the table angle, and then veering off about 20 to 30%. And it gives you an x-ray that looks about like this. It's still not gotten rid of the zygomatic arch completely, but we've got a much better view of the vast majority of those roots than we would have if we'd done kind of a normal bisecting angle view on that. The important thing to be aware of with those, because the plate's outside of the mouth, is that this x-ray will always show up in the opposite orientation than you're used to. So if you're used to mounting your x-rays labially, you look at this x-ray, you'd say, ah, that's the first quadrant. It's actually the second quadrant because it's outside the cat's mouth. So they always look flipped, even though they're not. It's really quite easy to tell that it's an extraoral view though, because you get all of the molars show up on the bottom there as well. So you know you've got the whole jaw in. It's something to just be aware of if you're communicating it with colleagues and sending them a bunch of x-rays. Label that one as extraoral. Then when you have done all your x-rays and all your probing and all of your other things and you're ready for extractions, open extractions can be quite daunting in cats because they've got that really thin gingiva, because they've got really small mouths. There's not a lot of space in there either. And we have a tendency with cats that we want to try and be as minimally invasive as we can, just because all of that tissue is quite friable. The first thing to really think about with them is flap design. Luckily, in a way, because the gingival line is quite thin and quite fine in them, you very quickly kind of get into that mucosal area where things are a lot more elastic and you can move them around. So a lot of your extractions of multiple teeth next to one another, you can actually get away with doing an envelope design where you just do one long incision. You can make it easier for yourself by making that long incision and then making the individual incision around each tooth. Just because that gum attachment to the tooth is really quite strong in cats, particularly on the palatal side. And sometimes you section it all nicely and your tooth wants to come out, and it's really literally just holding on by the gum. And then when you go to pull it, you pull all of the gum and then you tear it. So just remember to do a whole incision around each individual tooth. If you're struggling and you need to remove more bone to get to that tooth, then the first thing you can do is make that into a triangular flap. And then if you have to, you make it into a pedicle flap. The nice thing about flaps, they follow each other really quite easily. So you can just build them out to as much as you need and then use them to close it really nicely after that. We want to make sure that we're really getting that incision in the sulcus, that we're getting through that harder fibrous material that's holding the tooth onto the tooth. And that's because if we try and insert our instruments through that, then we're having to cut that before we cut the periodontal ligament, and your instruments are going to get blunt really quite quickly, and that's going to make your life harder as well. What can be really helpful in cats for that is these beaver blades. So they go on a round handle, and the round handle gives you a little bit more control for really tiny little fine adjustments as you're cutting around the tooth. And you can get them in different shapes as well. So the second one from the left, that's kind of more of a rounded head. It's an SM64. I use that for pretty much all of my dog incisions because it will cut downwards and to the side. And because it's quite a wide flat blade, you can already do a little bit of your elevation of the flap with that as well. But for the cats, especially small cats, you could consider having a few SM65s. They're really similar to, I think it's an 11 blade. I haven't used these blades for ages. In that it's really pointy. So it really just cuts at that teeny tiny tip, and that can be really useful to get into those really tiny spaces between the teeth in cats, but also to do a really full circular incision that ends up being less like a square if you would do it with the SM64. So they're really helpful blades. And then when you're doing your elevation, we talked about it earlier, you want to make sure you're not trying to slide the mucosa off the bone, but that you're really doing an elevation maneuver. So you're pushing it in a little bit, and then you're twisting your periosteal elevator to move the mucosa up and off the bone. And the easiest place to do that first is to start at the corners of your incision and to try and stay as close to the bone as possible. And that's why that little fine periosteal elevator is really quite nice, because it's very flat. It allows you to do that a lot easier in cats. Holding it properly also really helps. There are two ways to hold a periosteal elevator. But this is the safest way. So you're using this kind of finger stop grip. So if you do happen to slip or slide, which is really common in cats, happens all the time, then because of your finger stop, you can't go too far, and it minimizes the risk of perforating through your flap. If you do tear your flap, not the end of the world. If it's a really tiny little tear, what you can do is use a little monocryl 5-knot suture, just place a little single suture on the inside of the flap to bring those edges back together. So if it's just a tiny little hole, that tends to be absolutely fine. If you've gone through it all the way, you don't have to panic necessarily, because there's a lot more tissue in a cat's mouth to work with than we really think that there is. And we'll come back to a picture of that later with that maxillary canine. There are different ways to section the teeth that can make our life easier as well. I've included a bunch of illustrations here. So some of them you'll recognize are actually dog teeth, but some teeth, like the maxillary fourth premolar, look really similar in a dog and a cat. And I like using this kind of triangular incision first. So I don't section the mesial roots initially. I will section the mesial from the distal root, extract the distal root because it's quite triangular, so it comes out quite easily. And then go on to section the mesial roots, because I can then see where that furcation actually is. If you're struggling to see where the furcation is, the other option is to remove the crown from the mesial roots, and then it's really easy to see where it is. I personally like leaving a bit of the crown on because I have something to elevate against, so I like that. This is more of a dog with a first molar. This one is the mandibular first molar in a dog. And the main takeaway with this one and with this premolar is that the initial section that I'm making is angled in such a way that I'm going to be able to insert my instruments down into the periodontal ligament space in the same angle that the root is. And this is why, even if we're doing technically a closed extraction, making a little envelope flap and elevating that mucosa and gingiva a little bit just to visualize where things are can actually be really helpful, because it can help you determine at what angle you need to create these cuts. And obviously, that's also a thing that your x-rays are going to be really, really good for, particularly in the mandible where you can take those beautiful parallel shots. It's a really good representation of what the shape of the tooth actually is. And there's a version of the little molar in the cat. Depending on what is going on with that molar tooth, I prefer to use this kind of incision where I'm trying to leave as much bulk on that distal tooth because the distal tooth always breaks. I'd say probably 8 out of 10 times it still breaks. It's fine. We'll make a flap. We'll go find it. If the mesial root is really, really diseased, however, then I might flip that cut around, remove the mesial root first just to create more visualization in that area, and then go for the distal root. So it can still vary depending on what your individual patient actually has going on with it. If we need to do an alveolectomy, then we can help ourselves there by taking a little bit more time to make that as smooth as possible. This is kind of my first round alveolectomy. I'll use a round burr, and I'll remove some of the buccal-alveolar bone, and then I'll actually go back to it, either with a root tip burr or a small size taper fisher burr, and I'll just clean up those edges and also create little grooves next to each root to already have a place to start inserting my instruments. Not only am I making everything that bit easier to see, especially when it comes to the angles of the roots, but I'm already cutting through bits of periodontal ligaments. I'm already undermining the connection of the tooth, which will make my extraction a lot easier down the road. It also means that when you come back to do your little alveolectomy to smoothen everything out, you've already made a lot of things very round and very smooth, but then that ends up being a little bit quicker too. Now, if the worst does happen to you and you happen to put a piece of root where it's not supposed to be, which is going to happen to everyone, then the main thing to say to yourself is, when in doubt, take an x-ray. So this is one that I've done. I've obviously been trying to extract this teeny tiny little tip of a root, and at some point it's done the horrible thing where it's just suddenly disappeared. So instead of mucking around with it, the first thing I've done is take an x-ray to try and figure out where it's gone. And clearly it's gone into the mandibular canal, and on top of that, it's also moved forwards a little bit. So there's no way I'm going to be able to get it in this scenario because there's a big piece of bone sitting on top of it. So the first thing I did was remove a little bit more bone, create a little bit more of a window. So really what I'm doing is I'm not going downwards with my drill, I'm just widening the alveolus of the tooth so that I can visualize the bottom. There's going to be a hole there because the tooth's gone through the hole, so I don't have to remove any bone deeper down. I just need to make things wider so I can see where this root tip is. That wasn't quite enough. I can't quite get at it yet. So I removed a little bit more bone. That looks much better. I even removed the front root because at this point it was getting in the way and annoying me. And I think I was a little bit annoyed at the root tip, so I just went for something easy in the meantime and took a little break. But at this point, I've got a really nice straight access to that root tip. And then together with my loops, again, these are going to be super important in this, and a little bit of suction as well, just to kind of help remove some of that ooze that sometimes comes out of the mandibular canal. Even if it's not bleeding, it tends to be a bit pinky oozy. I was able to visualize that, and then my post-op x-ray to confirm that it's removed. So it looks scary. It's not terribly scary because actually the mandibular canal is a pretty big canal. It's got a nerve that's all bundled together lying in it. So if you're careful, you can gently push that nerve bundle to one side and try and find that root. But the easiest thing to do for yourself is just not panic. Don't go rooting around because you're going to misplace that piece of root a lot and then you're going to go and have to find it. But just try and figure out where's things gone wrong, how can I make my visualization better, and then move on to trying to remove it out. Then once we've done all of the scary things and we're definitely sure all of the root is out, it's time to close the flap. And I always kind of feel like this is coming to the kind of ridge of a mountain where you feel like, oh, I'm almost there. But then you're also almost at the point where you could potentially fall off the other side. And nothing is so clear as the really sharp ridge that gets hidden either on the lingual side of our mandibular teeth or on the palatal side of the maxillary teeth. Because one of the most common reasons for flaps breaking down is because of some sort of technical error on closing them. So either we didn't raise our periosteum enough and we didn't release the periosteum, so we've got too much tension on the flap. Another really common cause is that there's something really, really sharp under it. And cats have lots of tiny little ridges and bits of bone that tend to be really, really sharp. And if you don't elevate on that palatal or lingual side, those sharp edges are really not very obvious. And then as soon as you lift that bit of soft tissue, you'll see there's a really sharp ridge of bone there. But always check with that. Use your diamond burr to make sure everything's super nice and smooth. And then go looking for your periosteal ligament. The easiest way to do that is to make sure that your incision has extended past the mucogingival junction, because the gingiva is not actually attached with that. It's not stretchy anyway, so even if it was really attached with periosteum, if you incise the periosteum there, you're not going to win anything. You want to be incising the periosteum that's under the mucosa. And once your incision extends the mucosa, if you pull and put a little bit of tension on your flap, and you look really closely, you'll see that there's a tiny little separation between the pink side, which is the mucosa, and a little thin white kind of meshy type material that's under that. And that is that periosteal ligament. And that's the bit that we want to cut. And you can use a little fine pair of scissors to just blunt dissect between those two layers and then just snip it bit by bit. So you do a little bit of blunt dissection, pull those two layers off one another, and then just snip it. And you'll notice that suddenly there's way more to play with in that cat's mouth than you ever thought that there would be. One of the big things that we tend not to do with the maxi canine is we don't incise far enough upwards on the mesial side. So you really kind of almost have to go up into that lip groove to make sure you're in the mucosa, because the gingiva is really wide over that tooth, and not going quite far enough on the back side either to really get into that mucosa. And if you're not in the mucosa, you're not going to be able to see that periosteal tissue, and you're not going to be able to cut it either. Once you have, you'll genuinely be really surprised how much you can pull that down. But there's so many more reasons why we hate the canines. Everyone's seen one of these before. This is alveolar buccal bone expansion. And this tends to be linked to either tooth resorption or periodontal disease. And if we look at this tissue histologically, it's kind of like a low-grade osteomyelitis, not the type of osteomyelitis that normally needs systemic antibiotics. But what it does need is it needs proper debridement. That's a tooth that's really unwell, so that tooth probably needs to come out. And the best thing that you can do there is raise a flap over it and very gently burr that bone down to kind of a slightly more normal level. And then the only upside of that is that you now have more gingiva than you really need to close it. But it's very difficult to do if you leave it in that way that it is. And it's kind of semi-inflamed, semi-infective tissue that's just really bad at getting on top of its inflammation if you don't go in and help it a little bit. So you don't have to burr it right back down, but if you can bring it back to kind of the same level as the tooth on the other side, that's going to make that tissue a lot happier and a lot more likely to get on top of things itself. The other thing we all fear is fracturing the jaw. And this will happen. It's happened to me. It's happened to me multiple times. And sometimes this is because we're trying to extract a tooth that doesn't really need extracting in that way. If you've worked in a practice where you didn't have the luxury of x-rays, then you might have been dead set on extracting a mandibular canine that was actually resorbing. And then there's not going to be a periodontal ligament to put your instruments in. So all that force you're putting on the tooth is going straight into the jaw, and that might lead to a fracture. Or like this study, you might be looking at mandibular buccal alveolar bone expansion. So we've got exactly the same thing going on. This bone's already pretty weak. It's already pretty horrible. And because we've got all that expansion, there's not a lot of space to really do a lot of elevation, because that periodontal ligament space is already pretty wide. You put your instrument in and you try and twist it, and you can basically turn your instrument around in the hole. Then you try and find a place where you can get some friction and some grip, and you end up putting lots of force on it, and then this can happen as well. It's not always a massive problem if this happens, or say if we've got this case, this canine would still need extracting because this is a really unhealthy canine, and leaving that in the middle of a fracture site is not going to help it heal. But this cat also doesn't really have a lot of teeth left at all. So even if its jaw doesn't heal in the most perfect occlusion, it's not really going to matter for this cat because it doesn't have teeth that need to match up perfectly. For this cat, potentially just suturing up the soft tissues might be enough support for that bone to maybe not heal end to end, but maybe have like a fibrous union and still be pretty functional. But it's not always a reason to panic. Obviously, if it's a healthy cat full of loads of teeth, that might be a different story. And then we might want to do something different with that. So we might want to do something like a circummandibular wire if we've lost both of the mandibular canines, or do something like an interdental wire and splint to keep those two mandibles in the right position regarding each other, that they hopefully heal back together. There's always ways to fix things. And then the other one that we come across a lot is that people are really worried about lip entrapment. Please ignore that this dude looks really high. He is really high. He's post-anesthetic immediately, because that's the only time he'd do this cute little lip biting. I put a max reblock in his right maxilla, and he got a little bit of retrobulbar bleeding. So he had a little bit of exophthalmos during his surgery, which had pretty much resolved, but he still looks really asymmetrical at this point. He looked fine by the time he went home. And this could be a real concern, that he's got this lip entrapment bilaterally, except I haven't caused this because I didn't extract his upper canines. He lost them like 5 years before he came to see me. I extracted some other teeth while he was there, but he's had this lip entrapment for a really long time, and it's actually, he's chewing on his lip now because he's really high, but normally during the day he's learned that when he closes his mouth, he just needs to use his tongue a little bit to just flick those lips out. They hardly ever get caught, and when they do get caught, he doesn't bite down on them hard and cause any trauma. When we get this, it very commonly will cause a bit of lip trauma in the first maybe 2-3 weeks or so, but the vast majority of cats will learn to deal with it. And actually, if we look at the recent papers we have, there aren't any instances reported where it becomes a really long-term problem, with the exception of cats that have it because they've got a really significant malocclusion. So I have seen cats post-trauma that have a really bad malocclusion, and they're not able to flick that lip out because their malocclusion is so bad. So in that case, we might have to do something about it. But he just looks cute. That's the main thing. And then when we're finally all said and done, we still have to keep in mind that cats are cats and they like to be weird. So we do need to think about them a little bit more sometimes than our dog patients after surgery. They might either still be in that sense where they're not very well hydrated, or they'd be doing well with some extra hydration if they're chronic renal disease patients, or if they've had some lovely dips in blood pressure during our procedure. But we also need to consider whether, for instance, we're going to be able to get that IV out of the cat before it goes home. Bushu here, his face looks mad, but he also doesn't like people touching his feet. So he looks quite sweet, but he was, and ideally would have had some more fluids. But about half an hour later, we decided we were going to take his IV out anyway. We want to think about that analgesia. We're going to talk about our local blocks later. So some of those blocks will still be on board, they'll still be working. But we might want to think about, can we give NSAIDs now? Do we want to do that a little bit later? Do we want to send them home with just NSAIDs, or do we want to send them home maybe with transmucosal buprenorphine as well? There's a few studies out there that are showing that, especially if cats have had quite a few extractions, that a minimum of 3 days of transmucosal buprenorphine would be really beneficial, and they show much lower pain scores than if they're just on NSAIDs alone. And owners are really bad at recognizing this, and I think we're probably quite bad at recognizing this as well, because cats are really, really good at hiding pain. We need to think about when we want to feed them and what we want to feed them. I'm an ideally they'd have soft food kind of person, but I've got a friend with a Siamese cat who now doesn't have any teeth, and she hates wet food. She will refuse to eat it. She refuses to eat wetted down biscuits. So for her, it was kind of, I'd rather have you eat than not eat at all. So she just eats biscuits, and she's healed up fine. Yes, there was a slightly higher risk of it breaking down, but it's a much less risk than the cat just not eating at all. So we have to keep that in mind with our cats, that sometimes they can be a little bit more tricky to blanket recommend them all one thing. The same goes for indoor-outdoor access. Ideally, I keep cats indoors until I've seen them, so they can't go and pull their sutures or do something really stupid. But if they're really outdoorsy cats, and the alternative is they're going to climb up the walls because they physically are trying to break out of the house to get out, I'd much rather have them go outside and not do that than actually hurt themselves in the attempt to get outside. That's a good conversation to have, especially with those kind of semi-feral cats that might mostly be used to living outside in the barn and definitely not inside someone's house. You have to think about whether for those specific cats, hospitalization might actually be a better alternative, and that could be a number of reasons for that. Either because they've had really extensive extractions and they do better with some additional pain relief overnight, but it might also be because maybe our home situation just isn't really that good of a situation for them to be recuperating in. Maybe they've got a really long car journey, so maybe less if you're in primary practice, but sometimes we see people that come from hours away And it's not always the best idea for a cat to have a 4-hour journey in a car when it's just woken up from anesthetic. And sometimes keeping it in overnight is going to be a lot easier for that owner. Keeping the owner in mind is good too, because not all owners can drive in the dark very well. And that's definitely happened to me before. And then how often do we want to see them back for follow-up exams? And to be fair, I don't even think this is necessarily a cat thing. It might be more of a dog thing for some dogs as well. I think if it's really unlikely that you're going to be able to look at the cat's mouth when it's in and it's going to get really stressed from coming in, then there might not be a lot of point coming in for a post-op exam, because it's not giving us any extra benefit and it's just adding to the stress of the cat. And in that case, it might be easier for the owner to take a picture at home when it's yawning or when it's eating something really nice, or for the owner to just come back if they've got any concerns, or if there's halitosis or the cat is eating weird. If we prep the owner what to look out for, they can actually become really good at spotting these things once they've learned about it. So that's something to keep in mind as well. And then our ongoing monitoring as well. I always put this one in, and it's got to do with tooth resorption again. Tooth resorption is a progressive disease. We find tooth with tooth resorption, very likely we're going to find more teeth with tooth resorption. Not all of them are going to be indications for extraction straight away. And even if there were no other signs of tooth resorption at the time of exam, it's pretty likely that that cat will go on to develop more tooth resorption. We need to prep owners about those things. So we get a monitoring plan in place and we figure out how often we're going to see these cats back, make sure that we're not missing any disease in an early stage and then leaving them to be really painful for a long time.